you've been well primed, I think, if you attended the early session, because you can probably work out where this is going to go. But until we get there, I'm going to do a little bit of background for you, and I apologise if you've seen any of this before, and also if you know this, but I don't think it will be a problem to try and reiterate what we've learnt from this pandemic so far. Well, how is this virus transmitted between people? This is fundamental. We need to know this to be able to put in the infection prevention precautions, because this century is a century about transmission. Last century, antibiotics, vaccines. This century, transmission for potentially untreatable infection. Well, 3 possible ways. You could touch somebody, you could touch something that's been contaminated and transfer it yourself to your eyes, to your nose, to your mouth. Number 2, large virus-containing droplets will fly out of the mouth of an infected person and land on you. And finally, aerosol transmission, tiny aerosol particles from the air that you would breathe in. And these are tiny, very tiny, less than 1 micron. You can't see them. They're just like cigarette smoke. Now, even now, 2 years, more than 2 years after the pandemic, we still have no concrete proof for any of these, although there is some suggestive evidence for one of them. And the reason why is that this is an enveloped virus, very difficult to capture and difficult to culture as well, as you'll see. Well, is the virus on surfaces that we touch? I'm sure you saw the chaps in hazmat cleaning the streets of various cities across the world with, no doubt, powerful disinfectants. Were they justified in doing that? Were we justified in all the attention on hand hygiene and cleaning? Well, yes, it does survive on surfaces in a laboratory with carefully controlled humidity and temperature, but it's not actually that happy in the real world. And now that the evidence is beginning to accumulate, there are now systematic reviews coming out saying that direct contact and fomite transmission is presumed, but probably unlikely as a mode of transmission. And that seems to be getting stronger by the day. So yes, it's on surfaces, but we don't think this is the main mode of transmission. Is the virus in hospital air? Well, there was a very important landmark study towards the beginning of the pandemic, or just after it had started, whereupon this particular team, using very special collection equipment to find the virus, went into patient rooms, and they found the virus in aerosol, in the air. They also found it in the absence of so-called aerosol-generating procedures, which are things that make patients cough and splutter, like tracheostomy and sucking out and all the rest of it. They also found, with genotyping, that the strain from the patient matched the same strain they found in the air. And that's some of the main suggestive evidence we've got for the link between airborne virus and patients. And another study, which I need to mention, exactly the same again, and this time they put a filter on, a special filter, to be able to determine the size of the respiratory particles that they were collecting from hospital air, and showed without doubt that they were very small, so less than 1 micrometer. And the little picture there of the cell culture, you can see, this was really special because it's very hard to grow this virus in tissue culture. Not even sure Vero E cells are what they're using, E6 cells are what they're using nowadays to try and grow it. But you can see there the cytopathic effect in D, where the virus was growing and developing and destroying the cells in the cell layer, the monocell layer there. And this is landmark because most folk looking for the virus will do the swabs, et cetera, from surfaces and do the air sampling, and they may be able to detect it using PCR, but that doesn't tell you whether it's infectious or not. You've got to grow it, and you need probably at least 300 virions in cell culture to determine the CPE. So 2 very important studies there right at the beginning. Why does size matter? But of course it does. So we know now, and I think this has been really quite nicely elucidated by two previous speakers, is that particles of many sizes can hang aloft in an enclosed indoor environment, travel far, and be inhaled. And this distinction between tiny aerosol and relatively big droplet is rubbish, because there is a whole range of different sized respiratory particles which are produced by people who may not realise they're infectious. And these droplets, stroke aerosol, stroke respiratory particle, whatever you'd like to call them, are going to behave not only according to their size, but to the prevailing conditions within that room. So humidity and temperature, even your own thermal plume. If you produce aerosol full of virus, and there's more virus on the tiniest particles than there are on the droplets, conversely enough, then these aerosol particles will actually travel upwards in your thermal plume. And you can see all the electrical equipment in here. The warmth generated by that equipment will also take the particles all over the place. So, all this argument about whether it should be 1 metre or 2 metre, almost completely irrelevant. Yes, droplets are produced when you sneeze and cough, when you're symptomatic, and they fall to the ground. But the tiniest aerosols of all will hang aloft in the air. And in actual fact, it's all about time dependency. If you're in a high-risk environment indoors with aerosol being produced, you will ingest or inhale enough viral particles to cause infection. So it was the time factor, the third dimension, if you like, we were missing at that point in time. Well, this paper's already been expounded on by Yvonne. Trish Greenhalgh in the Lancet, although she's done a couple in the BMJ as well. And they put together 10 reasons why they felt that this virus was being spread through the air as tiny respiratory particles and not necessarily as the droplets. Because as Yvonne also said, the fact that everyone was fixated on droplets meant that we did all the PPE according to that, rather than embrace the precautionary principle and use the upgraded respiratory protection, which in fact all healthcare workers should have been issued with right from the word go. And I think there are lots of reasons why the World Health Organization got it wrong, and there were lots of reasons why the governments across the world followed them and got it wrong, and now we have got quite a lot to do to put it right. So you see super spreading events, and I was involved in looking at one of these in a choir, and there was a bus as well, there was a restaurant, there was a car, I think it was a yoga class, there was a church. How can all the folk that get infected in these particular venues do so by touching exactly the same spot and then into their eye or into their nose or wherever? It just doesn't work like that. These are tiny aerosols being produced which hang in the air until subjected to a ventilatory removal, whatever that may be. So I'm not going to carry on with that. Just to say that the last paper I saw trying desperately to prove airborne transmission was a lovely one using golden hamsters. I hope there are no golden hamster owners in here, but I assure you these animals came to no harm. They have a mild version of SARS-2, and they connected 2 cages with golden hamsters, those that were infected, those that were not, and the only way that the organism could reach the uninfected animals was through a duct with filters. And yes, the uninfected animals did actually pick up the virus. So it's been done with ferrets and cats and various other animals as well. Funnily enough, you'll not get ethical permission to do that with people. Well, let's cast our mind back to the situation in Lanarkshire. And I'm going to choose one of the worst periods that we faced as a health board. And here you see Scotland, and the red areas depict where the highest amount of COVID was being detected. And this was end of October 2020. And I'm going to look in detail at 6 months from October the 1st, 2020 to March 31st, 2021. And you'll probably remember what was going on at that point in time. There was a raft of restrictions that all came in, not necessarily at the same time. So masks in supermarkets, indoor venues, adult education closed, School children, senior school children were asked to wear masks as well. People told us to work from home, only essential workers, coming in dribs and drabs. And you can see that NHS Lanarkshire is right in the middle of the highest amount of transmitted COVID in Scotland at that point in time. So here we have the rate of positive cases of COVID, and the top graph shows you the rate for Scotland overall, and the graph beneath shows you the rate per 100,000 people in the community for Lanarkshire. And you can see straight away that we had the first curve, first pandemic phase, if you like, which doesn't look very impressive, but that's because we didn't have the testing then. And then the second wave of the pandemic biphasic, possibly biphasic because of all those restrictions that were coming in bit by bit. And you can see that it was taking off at the beginning of October. You can also see that there were more cases, more rate of infection, higher rate of infection in NHS Lanarkshire, excuse me, than there was in Scotland overall. So let me just describe NHS Lanarkshire. We have three large, moderate to large district general hospitals, very busy, semi-rural, squashed between Glasgow and Edinburgh. We have Haremyres, Monklands and Wishaw, and there are some centralised services, although all offer accident and emergency and critical care. And in particular, orthopaedic trauma centralised at Wishaw. So across NHS Lanarkshire there are about, I think it was 79 care homes, but that figure does go up and down a wee bit. So we were experiencing clusters right from the word go, as soon as the second phase hit of the pandemic. And clusters are defined as 2 or more patients, whether they're in care homes or in the hospitals, and or staff, testing positive and linked in time and space, which is our standard definition for, if you like, a cluster, or, of course, as it gets bigger and involves more people, an outbreak. So what did we do? Now, I think I've skipped a line. Yeah, there we go. Wonder where it had gone. Now, this graph, it's a little bit dark, and I'm sorry about that. This graph shows the number of clusters across this very important 6-month period from the 1st of October 2020 to the 31st of March 2021. If you look at the big green line there, that's actually, each one of these points is a cluster, so a defined transmission of COVID between at least 2 people, usually more. And the green line there are the care homes in NHS Lanarkshire, and this shows that biphasic nature of the second phase of the pandemic, if you like. You can see it going up and down. And you can see also that the blue and the green there were Haremyres and Monklands hospitals, clusters within the hospitals, and they sort of follow the outline of what was going on in the community, as the care homes did very nicely. But Wishaw was a little bit different. The cases in Wishaw took off with clusters and outbreaks and wards closed. And at one stage, I think we had 9 wards closed just before Christmas, with the possibility that the whole hospital might be closed for Christmas. And this was an utter disaster, because these were people who were coming in with other conditions, not COVID, who were catching COVID in the hospital, and some were dying. So this was an extremely serious situation. And straight away, beginning of December, we got the outbreak committee together and we reviewed what was going on. And for those of you that work in infection control, these are probably the standard things you would choose for all the things you would do when you've got outbreaks in the hospital. So we tried to isolate patients, but when there was evidence that a patient and or member of staff or both had transmitted it on the ward, we closed the ward straight away. We took the cleaning up. There was already a lot of cleaning ongoing. This time it was 2 full cleans for any affected wards with additional hand touch sites. And we were using bleach. Normal routine cleaning was detergent only. Bleach was being used. Patients and staff were being screened. Patients had been screened all the way through. Staff screening came in towards the end of December. So we were not routinely screening staff at first. That came in. Everyone was asked to wear a face mask, and there were all sorts of problems related to that. Visitors were restricted, etc., etc. There was a ward ventilation review, which I'll talk about later on, which had actually happened in the November. And we went walkabout. We went walkabout in Wishaw to try and work out what was going on in this hospital, which was not happening in the other hospitals. Because clearly there was something going on at Wishaw that was not being emulated, either by what was going on in the care homes, where the rates had been coming down, or indeed the other two hospitals. So there was some pretty complex operational management here. We'll credit to our senior managers for what they did. It looked as if the hospital was going into meltdown, so patients were diverted to other hospitals and to other health boards, and we thank them very much indeed for their support. We tried to restrict patient movement because it was pretty obvious patients were still being moved around the hospital, and it was thought that maybe this had a bearing on what was going on, because when we looked at the wards being affected, the wards on the ground floor were becoming involved with clusters and outbreaks and being closed, and then it fed up onto the next floor. So it looked as if there was a transmission going on within the hospital, which could only mean staff or patient movement. So we tried to restrict that. And of course, patient and staff vaccination began, notably care home staff first and care home patients from the middle of December, and then on drawing in frontline staff in the hospital. So that was started in the middle of December. Well, wearing a face mask is not part of the British culture. You'll see it in Southeast Asian countries, particularly where they've had SARS-1, and Middle Eastern, where they've had MERS and so on, where it is part of the culture, but not in Britain. It was difficult to get that through, and because of the mixed messages coming from government and the World Health Organization, it was difficult to get the public to accept it. Perhaps we had a slightly easier way of doing that in the hospital because, of course, it not only protected you, but it could protect other people as well, and that's what hospitals are all about. So we got posters printed, and we tried to make sure that everybody wore masks. You can't wear a mask all the time, though. And not only do patients take off their masks to eat and drink, and indeed to sleep, and some, of course, can't wear masks anyway, but staff take off their masks to eat and drink as well. And that was a pointer for us later on in the outbreak when we realised what had been going on. Well, we looked at toilets. I was a bit fixated on toilets at the time because I'd been asked to join a DEFRA group looking at risks from COVID in the environment. So this was a group of chaps, sewage, wastewater, swimming pools, milks, foods, etc., etc. I had a great time. I was the only clinician on the group. So I really enjoyed myself. And I asked them, being an infection control person, if they thought about the risks from toilets. And nobody had. So we pulled together some references and wrote an article, because it transpired that whether you believe in hand touch, COVID, droplets, COVID, aerosol, COVID, all of those exist in a small, poorly ventilated, potentially poorly maintained indoor toilet. Because we knew at that stage that fecal and urinary aerosol contains virus. And in fact, had been picked up in wastewater, and the sewage folk were using wastewater to track what was going on in the community. So we felt that toilets posed a risk. And one thing we'd seen on our walkabout round Wishaw was the fact that the toilets tended to be non-ventilated, and they were on the inside of the building. They were also aligned to a changing room. There was a big corridor outside, but there was no ventilation, because in company with most NHS hospitals, natural ventilation is the rule of the day in routine wards. So we put together a little list of things to do about how not to catch COVID in a toilet. And I'm diverting a little bit because we didn't manage to get all of these implemented in time, but we were able to raise the awareness risk. At one stage, we even decided we would have some lights on the outside of bathrooms, red and green, so you could go in if it was green. If it was red, you had to go and find another toilet, which doesn't work well practically on a busy ward, but these were ideas that we had to try and restrict folk going into the toilet and exposing themselves to risk. By the way, number 7, do not spit into wash basins. That wasn't me. That came from Professor Yugyo Li from the Chinese University of Hong Kong, because the Chinese culture, apparently, their spitting is performed in public and in toilets, and he was adamant that we should put that into our little list of do not do this in the toilet. So we did, just for Yugyo. Air. Another thing that we'd discovered by the walk-around hospital, Wishaw Hospital, was the fact that it seemed very stuffy. Of course, the first sub-zero temperatures of winter had just come the last week in November, first week in December, just when all this took off. And it was thought at the time that maybe the ventilation wasn't quite up to scratch here, and that maybe pre-symptomatic or asymptomatic staff, possibly patients, were seeding aerosol, infectious aerosol, into the air on stuffy wards, whereupon it was just hanging there, waiting to infect others. So we decided to go with an open the windows policy. Now, for those of you that work in the NHS, I wonder what the average time is to get a policy like this implemented quickly. 0, I should imagine, after it took me 10 years to get MRSA screening sorted out. So opening the windows in the middle of winter in a semi-rural health board, where it's pretty cold anyway, because Lanarkshire is higher than Edinburgh and Glasgow, was perhaps going to cause a problem, except it didn't. Except in this case, unlike the World Health Organization and various governments, here the experts are listened to in this health board. And they said, we'll go with you on this. Let's do this. We're going to open the windows in every clinical area for 15 minutes, 3 times a day. Was this an arbitrary choice? No. We found a set of guidelines from various ventilation engineers from ECDC, the European Centre for Disease Control, from all the different European countries. And we lifted this from the Danish version. We also checked, using A-level physics, exactly how many quanta, which is a sort of nugget of infection produced by infectious people, and how many people could be infected by that and how long it would survive in a particular sized area. We did some back-of-the-envelope calculations and worked out that opening 2 windows in a 4-bedded bay meant that we'd actually clear all the virus, so complete air change, within about 4 or 5 minutes. So this was enough for senior management. We showed them the back-of-the-envelope calculations. We showed them the guidelines. They went with us. We got the posters produced, and off we went. Did I implement an audit of any sort? No, I didn't need to. The infection control nurses came back and said, we've got the windows open. Did anybody complain of the cold? Well, I've no doubt that maybe some of the patients did, and I hope that they were able to get a remedy for that. But I did actually get accosted by a couple of consultants who wanted me to buy them jumpers. So, let's have a look. Let's just go back. Let's have a look at our original graph there, showing you what was going on in the community and what was going on in the hospitals. And one thing we noticed, I've got in there the sub-zero temperatures. So there were 3 times during that winter, I don't know if you remember or not, where we hit temperatures of like -8 for a week or so. So that was the end of November, beginning of December. Then the beginning of January. Do you remember January, New Year's Day? 2021 was really, really cold, and that was for a couple of days. And then there was another dive down of temperature in February. And looking at what was going on in the community, mirrored by the clusters in the care homes, we actually felt that there was a link here between cold temperature and more cases, because the downward trend that you've got there before the first sub-zero temperature stalls a bit in the care homes. Well, they're not opening the windows because it's cold. But we also know the virus survives a lot better at 0 degrees than it does, and at lower humidity. And then the sub-zero temperatures, again in January, we accelerate the number of clusters in the care homes, and there are also a whole load more little clusters going on in the hospitals as well. And then, of course, we open the windows January 25th, and we have another batch of sub-zero temperature. Once again, you've got the decreased stalling in the community care homes, possibly because of that week of very low temperature, but not a lot was happening in the hospitals at that time. Was there any discernible benefit then from opening the windows, the way we asked NHS Lanarkshire to do so? Well, there were 17 clusters altogether, and clusters range from 2 to, as you can see, all the way up to 24 patients we had in one cluster, and 17 staff in another. And some of them lasted more than a month. An outbreak on a ward for over a month before we could say this outbreak's over and open the ward. So 17 involving 14 wards up until window opening, and then there were just 2 at Wishaw after the window opening, which you probably saw on that. There was 1 new cluster at Monklands, which didn't involve any staff, it was just 6 patients, and no new clusters at Hare Myers. So this is a schematic diagram of Wishaw showing the amount of patients and staff, and the wards anonymised, the level 1 and level 2. And this is November, early November, and we finish in, I think, the first week in March. And you can see there what was going on at Wishaw during that awful, awful December, and what happened after we opened the windows. But it's not quite as straightforward as it looks, because there are points for and points against. Now, the points for was that there'd been in overall 40 outbreaks of COVID, reduced to 3 after the window opening. And this was at a time of continued high number of patient admissions. There was a high rate of COVID in Lanarkshire. There were more care home clusters at the time of window opening than in December. And there were lots more COVID patients in the hospitals at the time of window opening. So it's not as if everything had diminished. We had all the numbers coming in and they were being infected. And we had all that to contend with. There was no discernible impact on the staff screening that was introduced towards the end of December. Patients had been screened throughout. And we didn't see any link between, whether that's true or not, any link between cold weather and new clusters after the window opening. That had been a week of exceptionally cold temperatures in February, so we didn't see what we were expecting to see just there in the hospitals. But the points against is, do you remember the lockdown on Boxing Day? Cases were already coming down. You can say, well, actually, cases were coming down anyway. This doesn't say that opening the windows had any effect. We'd also reduced the boarding for orthopaedic trauma patients, who were the ones that were actually going all around the hospital at that point in time during December. I'm going to show you a graph about that in a minute. And also staff vaccination. Did that have an impact? Well, it was the care home staff that got vaccinated first. I don't think any of the hospital staff had even received their second dose until February, or the end of February, and the windows were opened in January. So I think this is perhaps a better idea of exactly what impact we had opening the windows, and that is the mortality rate. And numbers in red, number 5 at the top there that you can see, these are hospital-acquired COVID deaths, and we used the Health Protection Scotland definition for hospital-acquired. And here we've got October down to March, and we've got Hare Myers, Monklands and Wishaw. And we've also added in the admissions, total admissions, and therefore we've got the mortality rate for hospital-acquired COVID. So window opening occurred here, January the 25th. Look at the mortality and mortality rates after window opening. They plummeted. I can't prove that window opening had any effect on mortality, except to say that if we were diluting the air in clinical areas across all 3 hospitals, then if patients were still getting infected in the hospital, they were taking in a much lower inoculum. And we already knew at that point in time that a high inoculum, a high dose, meant you were more likely to have more severe disease. Perhaps we saved a few patients getting COVID. Perhaps we saved a few deaths from that as well. So what caused it? Well, I've already intimated, really. But here we've got the end of November, and you can see what the rate of boarding was for our orthopaedic trauma patients. This service specialised and centralised across the whole of NHS Lanarkshire. And right here was the cold weather. Old people fall over in the ice and snow and they break things and they come into hospital. And our trauma pathway was quite complex, involving both admissions, level 1, and level 2. And you can see that the rate of boarding exactly mirrors the rate of clusters and ward closures that we experienced at Wishaw during that December. We tried very hard over Christmas to try and reduce the boarding, and indeed it was coming down by the time of window opening. So coincidentally, a research group from the Institute of Occupational Medicine had contacted NHS Lanarkshire much earlier in the year and said, we'd love to come along and do some sampling in your hospitals. And they came along in November, and they actually went to Wishaw, and they did some sampling. And you can see the results there. They found virus RNA on surfaces, and they found it in the air. And they also measured the ventilation in several areas within the hospital, including patient rooms, bathrooms, staff rooms. And they found virtually all of those that they measured were below the usual recommended ventilation air change. They did a model prediction. This paper, I think, has been submitted, and found that infection was far more likely to occur through air inhalation and not from surface contact. We didn't know any of this at the time. This has only just come in. So the conclusions. This virus was brought into the hospital from the community, probably by staff, both asymptomatic and pre-symptomatic. Staff take their masks off in staff rooms, which were not ventilated, and in actual fact, without lots of door opening and closing and all the rest of it in these areas, viable infectious virus will hang in the air one particular day, and it will still be there the next day, and will still be there in enough quantity to infect somebody going into that staff room the next day. No ventilation whatsoever. So we think that staff were bringing it in as one of the main drivers and passing it to patients. And very sadly, our frail orthopaedic trauma patients, who were all going all over the hospital at that point in time, were particularly vulnerable, and this is reflected in the mortality rate because a high proportion of the mortality rate at Wishaw were these patients. There was absolutely no doubt that the poor ventilation, or perhaps I should say inadequate ventilation, in the hospitals contributed to this. And I echo very robustly the folk in the previous session who call for clean air quality. So introducing this open the window policy might have helped control what in effect was a disaster in one of our hospitals and reflected across the rest of the health board. I'd like to pay tribute to all the staff in NHS Lanarkshire, particularly my colleague microbiologists, those in the lab and those along with me trying desperately to try and sort things out. The infection control staff, public health, our managers who listen to us, and indeed estates, and very much so our cleaning staff. Some genotyping was done, and thanks to Public Health Scotland for that, to show us that we didn't have a new, very, very, very infectious variant. It was still the same one that had been doing the rounds since the previous year. Miranda Lowe and her team from Edinburgh for their support. And finally, a fantastic group of ventilation engineers and aerosol scientists and physicists across the world who knew right from the word go that this virus was spread through the air and did their utmost to try to bring it to everyone's attention. Thank you very much.